Hello and welcome to a very special edition of Caffeinated Chest Cases. The 2024 edition of the European Congress of Radiology has just ended, but the good news is that I was there, I took some notes, and I am eager to share them with you. So the first noteworthy session was on the 1st of March, which was a Friday, and it was titled Chameleons in Thoracic Radiology. There, the first lecture was given by Professor Cornelia Shaefer-Prokop from the Netherlands, and it was titled Pulmonary Metastases Not Always as They Seem. The professor started off by saying that metastases are the most common malignancies in the lung and that the lungs are the most common site of metastases. Pulmonary metastases usually come from the GI tract, like colon cancer, pancreatic cancer, the GU tract, like kidney cancer and bladder cancer, melanoma, and the breast. The typical appearance of several solid, sharply marginated, round nodules are found in breast cancer, colon cancer, kidney cancer, melanoma, and sarcoma. Cannonball metastases, which are larger than 5 cm, are typically found in kidney cancer, bladder cancer, sarcoma, and testicular cancer. Beware of metastases which come in the form of spiculated nodules, because they can be tricky, especially when they are solitary. They can be even more tricky when they are due to benign etiologies like sarcoidosis, lipoid pneumonia, and GPA. The latter stands for granulomatosis with polyangiitis. Cavitating metastatic nodules are typically found in squamous cell tumors, sarcoma, colon cancer, and bladder cancer. However, the list of diseases that come with several cavitating nodules is quite large. So, for example, other etiologies with cavitating nodules may be aspergilloma, rheumatoid arthritis, GPA again, tuberculosis, and Langerhans-style histiocytosis, septic pneumonia, sarcoidosis, and a pulmonary infarct. Do you know what a lacune is? It stands for a nodule which starts off as a solid nodule, but then with time it gradually becomes a thin-walled cyst. This is actually a very good sign of therapy response. However, the exact opposite may also happen when you go from a thin-walled cyst to a solid nodule, and that actually indicates tumor growth. Consolidative lesions may also be metastases. These may come from adenocarcinomas like colon cancer, pancreatic cancer, and renal cell tumors. Hemorrhagic metastases are quite rare. They may be identified by the halo sign around them, and they can be found in choriocarcinomas, renal cell tumors, angiosarcomas, pancreatic tumors, and melanoma. However, similar nodules may also be seen in some types of infection, organizing pneumonia, and granulomatosis with polyangiitis. Be careful with calcified nodules because we tend to think of them as benign nodules like granuloma or hematoma. However, sarcomas, mucinous tumors like a pancreatic tumor or ovarian cancer, small bowel cancer can also cause calcified metastases, and let's not forget that dystrophic reactions may also be behind such morphology. She emphasized that infections, organizing pneumonia, vasculitis, and sarcoidosis are the best mimickers of pulmonary metastases, and the end of her talk was reserved for two uncommon types of metastases. The first one was the pulmonary embolism pattern, which may be complicated by cor pulmonale, and the second one was the endobronchial pattern, which may in that case was due to breast cancer. So the take-home messages were that you have to be very careful because the morphology may be misleading. You really have to know whether malignancy is a possibility. It would be ideal for you to know the histology, and you have to prove temporal progression, and you have to put all that information into a clinical content, and last but not least, a biopsy would be ideal. So this was the very first talk in the session titled Chameleons in Thoracic Radiology. I think the professor nicely highlighted the several phases of pulmonary metastases. She also talked about some caveats and gave us some hints on how to narrow our differential. If you like this video, please come back next time because this session also had 2 other very interesting talks. The second one was about the many phases of lung cancer, and the third one was about benign lesions and diseases that may mimic lung cancer.